Okay, we're back for yet another case of shortness of breath, which will allow us to talk some more cardiac, some more pulmonary. 24-year-old woman presents to the emergency room with severe shortness of breath. Okay, this was a single best answer. I'm skipping to the last line of the question, seeing what they're going to ask me about. Let's put me on pause and read the rest of this history, and then put the play button back on when you're ready for more punishment. Okay, so again, 24-year-old woman presents to the emergency room with severe shortness of breath. Her family states that she has a history of asthma and a chronic nasal stuffiness. So she's shortness of breath and asthma. Sounds like an asthma attack. Chronic nasal stuffiness. What do I think? Nasal stuffiness. Is there something in her nose? Asthma, nose, nasal polyps maybe. She has been maintained on a bronchodilator and a steroid inhaler. Sounds like appropriate medications. She recently developed an upper respiratory infection and began to wheeze mildly. She has been taking an over-the-counter cold medicine over the last day. Now, whenever I see the word over-the-counter medicine, I have to stop and think what they're talking about, because often they're not telling me for a reason. Because often patients won't tell me, and they want you to figure out what they're on. Over-the-counter cold medication? Well, maybe it's a non-steroidal, because I already got that connection of asthma, maybe nasal polyp, and now an over-the-counter non-steroidal, there's my triad. Okay? Otherwise, there's nothing terribly atypical for a bad asthma attack here. She's on the right medications. She developed what most asthmatics, or many asthmatics, get before an exacerbation. That's an upper respiratory tract infection. This afternoon, she developed acute worsening of her breathing and called 911. So far, it sounds like a straightforward case of asthma. It doesn't sound like this is going to be a problem in diagnosis, maybe in management. Afebrile on physical exam. Imagine this is CCS, just one line on the screen now of vital signs. Blood pressure 180 over 100, pulse 120, respiratory rate 36. Stop. Is this an acute emergent problem, or is this a stable chronic problem? Which one do you think this would be? This sounds like an acute emergent problem. She's not a deathly ill woman, not yet, but she has a severe asthmatic attack is my hunch. And I don't think this is going to be a question much about diagnosis. I think this is going to be a question about management of an acute asthmatic attack. So if this was the CCS, you would now get the rest of the history, then have to do stuff. If I have to do stuff here, I'm probably going to start my treatment here without doing much more of a physical than perhaps a lung exam. All right? Now, this is what we're given in this question. The patient appears agitated, restless, unable to speak in full sentences, and she's using accessory muscles for breathing. Obviously, severe asthma. She has discharge from the nose and a nasal polyp is visualized. Okay, confirms what I already suspected. And in fact, if I was choosing the segments of the physical exam to pick, I probably, in this case, would have done a head and neck exam because of that, quote, nasal stuffiness and the over-the-counter medication. She has a paradoxical pulse seen on the jugular venous pulse with inspiration. Lungs show minimal breath sounds with faint expiratory wheezes heard throughout both lung fields with a prolonged expiratory phase. Now, what have I been told so far in physical? Is there anything that is not consistent with my diagnosis of severe asthma? No. In fact, there's a lot of evidence she is having severe asthma. She's tachypnic. She's tachycardic. She can't speak in full sentences. Accessory muscles, meaning the strap muscles, the sternocleidomastoid, and the internal intercostals. She got that nasal polyp. Minimal breath sounds and faint wheezes. Is that a good sign? Faint wheezes? Not too much wheezing? In her case, it's a terrible sign. Because remember, what is wheezing? Wheezing is turbulent airflow through an obstructed airway. I mean, it's turbulent because there is obstruction. And if it's so obstructed that there's no air going through, you're not going to even have enough air movement to make a wheeze. All right? A wheeze that sounds like this implies there's a lot more air movement than someone who looks like they're having severe asthma and can only make this much air movement. You get the picture. All right? So the fact that the wheezes are faint is a bad sign in this situation, not a good sign. She's tachycardic. She has a prominent split S2. Now, why is that happening? Do I now have to switch my diagnosis to some kind of cardiac disease, some kind of valvular disease? No. What's happening here? How does this impact on her? This asthma attack impact on her heart sounds. Well, remember, what's S2 comprised of? The aortic sound, the pulmonic sound. Which usually comes first? The aortic pressures are higher, so the aortic valve closes sooner, and then the pulmonic sound. So you have the S1, S2 split. Here's S1, here's S2. Let's say you have very high pressures in the right ventricle because there's so much high pressure in the pulmonary system, all right? And there's so much intrathoracic pressure being built up. Your P2 pressure, your pulmonic sound, which is which occurs when the pulmonic valve closes with a high ventricular pressure, the P2 is going to be delayed because there's very large intrathoracic pressure. There's more right ventricular filling, so the P2 moves out here. So you get a wider split S2. There's no S3 because this is not ventricular volume overload, and there's no murmur. Abdomen benign, extremity no edema. What am I thinking here? Well, here the differential diagnosis is not really a mystery. We've discussed a number of these entities earlier today. This is asthma. She has a history of asthma. They're telling me that. She has at least 2 causes for her asthma now. What does she have? She has nasal polyps with NSAIDs, probably. I still haven't heard for sure that it's an NSAID, but I would strongly suspect it. And number 2, she has a cold, meaning what I would interpret to mean an upper respiratory tract infection. In asthma, is that usually bacterial or viral? Viral, okay? There's nothing here to make me think of any of these, and we've discussed a number of these. Pulmonary embolus, again, the lung exam has a wheezing, prolonged expiratory phase, all signs of expiratory obstruction. Acute cardiomyopathy with CHF, there's no underlying cause for it. On the other hand, can CHF cause diffuse wheezing? The answer is yes. Sometimes you don't hear rales from fluid in the alveoli, but it presents with wheezing. We sometimes call that cardiac wheezing. But again, there's no S3 here. There's no underlying risk factors for coronary disease, etc. Is there some reason why she should have wheezing from a foreign body aspiration? Now, if this was a young child with the acute onset of wheezing without a history of asthma, you should always put foreign body aspiration in the differential. In adults don't, by and large, aspirate foreign bodies. All right? What you can get aspiration from in adults that will produce pulmonary symptoms is with a couple of things you can aspirate. In GERD, gastroesophageal reflux disease, when you lay down at night, acid reflux is back. You're laying supine, so you lose the effect of gravity washing acid out of the esophagus, and you will have aspiration of acid into the lungs, into the airways, causing bronchoconstriction and nocturnal asthma. That's one thing you might aspirate in this situation. The other thing you might aspirate in a pulmonary situation is if you had a loss of consciousness from whatever cause, whether you got a narcotic because you were having surgery, or whether you were using illicit drugs, whatever, or you had a seizure, anything that causes a loss of consciousness, I would worry about that you're aspirating oral contents. What's in the oral? What are the oral contents? Anaerobes, mixed anaerobes, gram-positives, gram-negatives. Then you get an aspiration pneumonia, often an anaerobic aspiration pneumonia. But adults, foreign bodies, you're not going to see that. Bacterial pneumonia, we don't have anything here. That sounds like a localized evidence of consolidation on a lung exam. There was no fevers. There was no rigors. This is not the productive cause of bacterial pneumonia. Spontaneous pneumothorax, no underlying risk factor. Now remember, you say asthma. Isn't asthma something to do with obstructive pulmonary disease? Yeah, it's obstructive pulmonary disease. So doesn't obstructive pulmonary disease have something to do with pneumothorax? Yeah, there is a connection. The connection, as we'll see in one of the coming cases, is that the patient who has chronic obstructive pulmonary disease, COPD, particularly the emphysematous forms big bullae in the lungs, which are thin-walled air spaces, and with a lot of cough, they can rupture one of those thin-walled bullae, and then they can get a pneumothorax. However, remember, asthma is entirely reversible, and so you don't have development of these big bullae. You have an acute episode, you get over it, and there's no damage to the alveoli in a chronic way. So you don't have pneumothorax typically happen in a patient with asthma. Although it is something that I would consider in a COPD patient who develops sudden worsening. But again, there too, you want to see the exam consist of pneumothorax, meaning loss of breath sounds on one side. Epiglottitis, that's not really so much shortness of breath, is it? Epiglottitis, also more common in kids. It's intense inflammation of the epiglottis, usually with H. influenza, Haemophilus influenza, and it presents with stridor, What's stridor? Stridor is basically turbulence to airflow in the upper airway. And where a wheeze sounds like this, a stridor is a much rougher sound. And you could hear it right here over the laryngeal area. That is a life-threatening emergency. And you won't see very many cases of epiglottitis in adults. For every one case of epiglottitis you're going to see in an adult, you'll see 1,000 asthmatics. The reason it's in the differential here is giving me an opportunity to discuss it because, again, it falls into that category of a disease you can't afford to miss. This patient will present to the ER. It'll be difficult for them to talk because they have obstruction in terms of phonating and making sounds. They'll have laryngeal stridor, that sound heard right over the neck, and they'll have trouble, and this is a very characteristic finding, almost pathognomonic on the boards. They're also, in the setting of those signs and symptoms I just described, are salivating because there's so much upper airway obstruction and so much posterior pharyngeal edema that their saliva can't get down to their esophagus and they're drooling. Okay? That's epiglottitis. Those patients need antibiotics, they need steroids, and many of them will need an emergent tracheostomy. That is clearly not what's going on in our patient. Now, how are we going to approach this patient? What's our initial diagnostic plan? Now, for a CCS question, I'm not going to start doing a lot of diagnostic tests here. I know this patient has asthma. What would probably be what I would choose to do next? If I know a patient has a severe attack of asthma and I want to start treating this patient's now in the emergency room. What are you going to consider doing? Do you need a test to help you make the diagnosis of asthma here? Do you need to do do you need to do spirometry and measure FEV1 and the FVC? No. What's the most important measurement you're going to make right here in the emergency room? That'll take about 1 second, give you a baseline, give you a quantitative measurement of outflow obstruction in the airways, and allow you to start treating the patient with a good baseline information. That test is a peak flow meter. The patient takes a big deep breath in and blows out as hard and fast as they can, like that, and that's a peak flow rate. All right? Now, every patient is different. Every individual, normals with or without asthma, have their own baseline peak flow rate. And in fact, an asthmatic between attacks is, quote, normal. They don't have chronic obstructive pulmonary disease. And the peak flow rate is dependent on a lot of things. It's dependent on your size, on your lung volume, on the strength of your intercostal wall in expelling air, because it's a rate. It's the speed with which you're forcibly exhaling volume of air. So you establish somebody's baseline. And for, say, someone of an adult size, normal in every way, you'd say 400 liters or so. Most peak flow meters don't measure below, say, 60 liters per minute. That's the minimum that you could show on that test. And if you have somebody who tells you that their baseline is 400 or 300 between attacks, because most of the asthmatics had a history already, and they tell you right now they're blowing 100, that's very severe impairment to that flow. And they give you something you then continuously can measure every 5 minutes, every 20 minutes, every hour, as often as you like, because there's no invasiveness to it, and it gives you very direct, instant information about airway obstruction. So I would say the first thing I would do is a peak flow rate. In this patient, I see that it's 100 liters per minute. Okay? That bullet there does not mean greater than 100 liters per minute. Let's take it to mean 100 liters per minute. Next, I might get an arterial blood gas, but CCS, that would be the wrong thing to do. If I establish this patient has severe asthma, I'm going to stop there. I know the peak flow rate is low. I'm going to start treating the patient. Okay? For the purpose of this teaching slide, we're talking about the diagnostic steps we might take. But in terms of practical management on CCS, you're not going to say, okay, let me do all my diagnostic tests. Let me get peak flow rate, blood gas, and chest x-ray. Wrong. You'll probably fail that question. They'll probably tell you the patient has stopped breathing. Thank you for your help. Please leave the room. Okay? CCS will sometimes give you a clue that you've done wrong. For instance, a 24-year-old woman comes into the emergency room and she's dead within 10 minutes because you've done a blood gas, you go back, have a cup of coffee while you wait for the lab to call you with the results. You say, let's get a chest x-ray. Oh, she looks pretty sick. Let's get a portable chest x-ray. The next thing you know, she's blue, she's hypercapnic, she's not breathing. All right? Thank you for your time in this case. You say, wow, man, I must have done a great job. It only took me 5 minutes to kill this patient. All right? On the other hand, you might get through a case, And the patient might die despite you doing everything perfectly on CCS. But obviously, in this situation, if you start doing these tests while your patient is having more and more airway obstruction, you're doing the wrong thing. So I wouldn't do a blood gas next on CCS. But what would a blood gas, from a teaching point of view, look like in this patient with severe asthma? I would expect, first of all, what I would expect, respiratory acidosis or alkalosis. Well, it's hard to know exactly where she is in her attack. Most asthmatics, until they're into respiratory failure, where they're really sort of pooping out, they've lost all their ability to continue to expire forcibly, most of them have a respiratory alkalosis, and they'll be somewhat hypoxic. Here she is. She has a mild, this woman already has a respiratory acidosis. She's further along in this episode than I would like. Despite all her heavy breathing, she was quite tachypneic. I believe her respiratory rate was 28. She can't even blow off CO2. That's how much obstruction she has. And she's already developed a respiratory acidosis. If a question gives me this scenario, or a CCS on a follow-up, tells me despite everything I'm doing, they interrupt you to say, the patient is getting worse, and you order a blood gas. You see this blood gas, they want you to do one thing. They want you to write in, prepare for intubation, or intubate the patient, all right? Because this patient has respiratory failure. This patient has only one way to go, and that's down the tubes. Literally, you want to put down the tube. You get it? You need to intubate this patient. And again, I wouldn't have done a blood gas on CCS. I would start treating the patient. Chest x-ray, I would again say this is big problem in CCS. This is where the patient's going to die, in the x-ray room, or waiting for that portable x-ray. What do we see from a teaching point of view, from a diagnostic evaluation of asthma? First of all, you need a chest x-ray in the vast majority of cases with an asthmatic attack, even a severe asthmatic. The answer is no. Let's say the patient on lung exam had something that sounded like a lobar consolidation. Then yes. Let's say the patient did have signs and symptoms of a pneumothorax. Then yes. Patient had a fever. Yes. Otherwise, even severe asthma, chest x-ray is almost never of value. What chest x-ray show? Normal heart size, no infiltrates. And again, if this was CCS, I'd be losing big points for wasting time here. Now, what are the clues that told me that right away that this patient had asthma? And I told you that I don't need to waste time doing a lot of diagnostic tests. Well, she had the typical precipitating factors, a recent viral URI, or some other things, not necessarily in this patient, that are clues that your patient's shortness of breath is asthma. If the question tells you clearly that there's some new exposure to an allergen, you moved into a new apartment, you got a new pet, you moved into someone else's apartment where there were just pets, and you might have cleaned the apartment, but the animal dander, some animal hairs are still left behind. You move to a new environment. The season changes. Anything that is a suggestion of there might be a new allergen in town, then you got to worry about cough and wheezing after that is asthmatic in nature. You all know about the specific scenario whereby people are perfectly well, and the only time that they have wheezing and bronchospasm, shortness of breath, is with exercise. And that's exercise-induced asthma, and as you know, that's one instance where a cromolyn inhaler might be my first choice. In fact, we can, and they'll also have you know that cromolyn is the wrong drug in exercise-induced asthma if the patient has already developed their asthmatic attack. Because after all, what does cromolyn do? It stabilizes mast cells from releasing their histamine. Once your patient is already having their asthmatic attack, their mast cell is already destabilized. It's released this histamine. Horse is out of the barn. It's not going to help giving that patient cromolyn. Cromolyn is the right answer if you want to prophylax against exercise-induced asthma, but frankly, I could use beta-2 agonists there as well. We'll talk about beta-2 agonists in a moment. Aspirin and NSAIDs, as in possibly the case in this patient, in the setting of nasal polyps, can provoke an asthmatic attack. How about severe asthma per se? What tells me that this is a patient, by definition severe I mean, might need prednisone, might need hospitalization, might need intubation? First of all, a very low peak flow rate is also a suggestion. Accessory muscle use, as this patient has, sternocleidomastoids, internal intercostals, diaphragmatic fatigue, all signs of a severe attack. A pulsus paradoxus, which is basically an exaggeration of the fall in diastolic pressure with each inspiration. Normally, with inspiration, there's a slight fall in blood pressure because the intrathoracic pressure increases and blood is filling the right heart at the expense of the left heart. In a patient with asthma, they're generating these large intrathoracic pressures. So that phenomenon I just described is accentuated. And there's a much bigger drop in the systolic blood pressure with the deep inspiration. That's known as a pulsus paradoxicus. In this patient, it was visible even on observing the jugular veins. Rising serum pH. Now, this patient, I told you, was frankly acidemic already. Had a pH of 7.36. Even if she came in with a pH of 7.52, and then I repeated a blood gas 20 minutes later because I wasn't comfortable with how she was looking, and her pH went from 7.52 to 7.46, I say, oh, good, she's becoming, quote, more normal. But if she still looks terrible, she's not becoming more normal. What's happening is she's losing her ability to blow off that PCO2 despite what looks like a lot of respiratory work. And her PCO2, which might have been 20 with a pH of 7.56, that's the right number. For every change in PCO2 of 10, your pH changes by 0.08. So if my usual PCO2 is 40, now hers is 20, that's a difference of 20. And for each 10, I change by 0.08. So this patient, let's say, was at 7.40. She starts hyperventilating down to a PCO2 of 20. She's now 7.56. Half hour later, she looks terrible. I do another blood gas, and now her pH is 7.48. Her PCO2, and she looks to me like she's working just as hard. Her PCO2, excuse me, is now, instead of 20, is now 30. That's the sign that bad things are about to happen. She's going to develop impending respiratory failure. Respiratory acidosis is coming. All right? So don't be fooled by a alkalemic pH if that PCO2 is starting to rise. Now, how are we treating this asthmatic patient? This comes down to sort of pure bread and butter, prioritizing treatment of the ER severe asthmatic patient. And this is where in CCS you can gain some big points, not only for mentioning the right therapies, but also mentioning them or ordering them in the right order. Okay? Now, how would this be on a single best answer? You would say, what is the next step in management of this patient? That would be the question you got to pick out of a list. And all 5 might be appropriate things that should be ordered for that patient. But they want you to understand in terms of priority and protocol what's first. CCS, you might say, give steroids. Wrong. Will this patient need steroids? Absolutely. I would bet you big bucks that this patient's going to need steroids if she's this asthmatic. Is that the first thing I want to do? Absolutely not. Because as you know, steroids in this situation, delivered either orally or intravenously, even intravenously, is going to take hours to work. All right? And I need this patient to get immediate relief. So what am I going to do for this patient? Well, first of all, I'm going to put some oxygen on the patient. And I don't have this on the slide, but these patients are either already hypoxic or they're in risk of becoming hypoxic. So I want to give the patient some oxygen if in single best answer, that's a choice, or in the CCS. Remember, this is asthma, not chronic obstructive pulmonary disease. I don't have to worry about CO2 retention by giving the patient some oxygen. So oxygen would be nice. What is the first pharmacologic therapy? A beta agonist nebulizer. Okay? Why? We've talked this morning about beta antagonists, beta blockers. And in fact, if you remember, one of the contraindications was bronchospasm. Beta stimulation in the pulmonary airways is to dilate. You get bronchodilation with beta stimulation. And there are a number of drugs in this class like albuterol, salbuterol, the Arol drugs. Right? They all tend to have the same suffix. Metoprolol, and these are beta stimulants. There's a lot of controversy about how to use beta agonists in outpatients and the patient's over-reliance on beta agonists to the exclusion of other more important medications. But everyone agrees that for prompt symptom relief, what works the quickest in this situation, this ER patient with severe asthma, is a beta agonist, beta-2 agonist nebulizer. In addition to that, we now have anticholinergic nebulizers because cholinergic tone is bronchoconstrictive. Anticholinergic is bronchodilating. So it's working in addition to the beta agonist by a different mechanism. And the sort of prototype of this kind of drug is ipratropium. And it's available as an inhaler or as a nebulizer. And in fact, You're not going to lose points by saying give it in a nebulizer if the question makes it clear that they have good nebulizer technique. If this is someone who's very jittery, maybe somebody elderly, maybe it's someone who's never used an inhaler, then it would be wrong. You'd lose points on CCS for giving them an inhaler. A nebulizer is that mask with a humidified mist of the medication. They have a mask on, and they're breathing like that. In fact, if you have good use of an inhaler, that works just as well. If I had to pick between one or the other, I would say nebulizer, so I don't have to worry about patient technique. Oxygen via nasal cannula. And again, I probably would use it before I even start the nebulizer treatment. And in fact, again, you're doing this almost simultaneously. Now, if the asthma is as severe as it is in this patient needs another medication besides this short-term. What we just discussed in terms of bronchodilation is short-term. That inhaler or nebulizer treatment doesn't last very long. Furthermore, not only does it not last very long in that route of administration, but there's a problem. Asthma is a consequence of two processes, right? Remember back to step 1 and step 2, those nightmarish years of your life? It's a process of bronchoconstriction, airway obstruction, right? Airway obstruction from bronchoconstriction, number 1, and number 2, airway inflammation. And the over-reliance on beta-2 agonists at home for attacks is one of the reasons that we still have patients, young, healthy people who develop fatal asthma, because they take a puff, they feel a little bit better from their beta dilator, but then they've done nothing for the underlying airway inflammation. And over the hours, they're using their beta-2 agonist inhaler repeatedly and doing nothing for the airway inflammation, which continues to progress, till the airways are all full of inspissated mucus and airway inflammation, and then it's too late. So early on, if someone has severe asthma, you want to get some systemic steroids into them to knock out that inflammatory response. Now, no matter whether you give it orally or even intravenously, that process to start reversing that inflammatory process takes several hours. So yes, I will do it, but in my rush to do the right thing for my patient, that's not going to be number 1, 2, or 3. Now, let's say you get the patient better. You treat them aggressively with your beta-2 agonist inhaler, your anticholinergic inhaler, your oxygen, and your steroids. And within the next 4 to 6 hours, patient's peak flow rises, the blood gas normalizes, the PO2 normalizes, the pulse oximetry normalizes. Everything's back to normal. You say, okay, I think this patient could go home. Although I would argue that a patient that came in this severe will probably not be well enough to go home in a few hours. So either the patient's going home from the ER or you sent the patient upstairs for a few days and now the patient's getting better on the medical floors. How do you treat this patient long term? All right? We talked about the acute emergent management of asthma. How do we talk about the chronic treatment of asthma? As an outpatient, the most important single agent, if you had to send this asthmatic off and they're going to be the last person left on the island in Survivor, and the cast and crew takes off and they're stuck on that island, what medication do you want them to have? You want them to have a steroid inhaler. The single most important medication for the outpatient management chronically of asthma is steroid inhalers, long-acting steroid inhalers. Now, there are a number of these, beclomethasone, fluticasone. There's a whole class of steroid inhalers, and they are generally used as twice a day, several puffs twice a day. They're long-acting. Do they do much for you or do anything during an acute attack? No. They don't give you bronchodilation in an immediate fashion. What they do is give you airway inflammation reduction and therefore fewer attacks and less severe attacks. What's the common side effect people get with a steroid inhaler? And this could appear as a question. Or you might even say, what other instructions do you give the patient? Rinse your mouth right after you use it, because if you don't, you get a lot of steroid deposit in your mouth and you develop a local infection in the mouth. What's that? Candida. Okay? Steroid inhaler, the hallmark, the bedrock of therapy for your outpatient asthma treatment. For symptom relief, you're going to use a beta agonist inhaler. But again, you've got to warn the patient. If you're using more and more of your beta agonist inhaler, it means your asthma is poorly controlled. You better be using a steroid inhaler as well. Let's say you're doing all this and still having symptoms. We now have oral medications that are inhibitory in the leukotriene pathway. Now, if you remember back to your biochemistry, this is really going back a long way, and I'm sorry to do this to you, but if you go back and you think about the two pathways, There's the cyclooxygenase pathway. All right, here's your arachidonic acid. Metabolized to the cyclooxygenase enzyme pathway results in prostaglandins and prostacyclin. Here's your other pathway, the leukotriene pathway. The enzyme there is not cyclooxygenase, it's lipooxygenase. Okay? The products of that lipooxygenase pathway include a number of leukotrienes, which are bronchoconstrictors. So I can antagonize lipooxygenase, or I can block some of those receptors with medications like zafirlukast, montelukast, xylutin, and inhibit that pathway or the consequences of that pathway, then I will get bronchodilation. All right? And if you think about why should patients with asthma have an exacerbation, whether or not they have nasal polyps, you take an asthmatic and feed them a lot of ibuprofen or a lot of aspirin, you're probably going to trigger an asthma attack. What does aspirin and Motrin, ibuprofen, do in terms of those two pathways? Here's my cyclooxygenase pathway. Here's my lipooxygenase pathway. Which pathway is being inhibited? Cyclooxygenase. So now more is being shunted into my lipooxygenase pathway, more leukotrienes, more bronchoconstriction. That's why aspirin and NSAIDs, which are, quote, anti-inflammatories, don't do anything in terms of anti-inflammatory in the lung, and in fact give you more leukotrienes, more bronchoconstrictions with aspirin or NSAIDs. Now, for some reason, patients with nasal polyps are more prone to this. Now, if you have an outpatient with asthma, and you're treating them with your steroid inhaler appropriately, and they're getting their beta-2 agonists, not only twice a day for maintenance, but also when they're getting their attacks, and you have them on a leukotriene inhibitor, and they're still having frequent attacks or are never getting quite better, that's a patient who should get prednisone. And in this disease, as in every other disease, prednisone is our friend and just as well our enemy. Because even though it is in a oral form, a systemic form, a very potent anti-inflammatory in the airways, we then have to deal with all the myriad side effects of prednisone. So my goal with prednisone is to get the patient well quickly with a quick taper. All right? So this patient who got better in the emergency room, maybe I'll send her home with 40 milligrams of prednisone a day and taper her quickly over several weeks. All right? Okay. That sums up our discussion of a severe asthmatic come into the emergency room, how we work it up, which is mostly history, physical, and peak flow measurement, how we treat her acutely in the emergency room, how we treat her chronically once she gets home, to get her into a full remission, and then to reduce the frequency of her attacks. Let's move on to the next case. And 65-year-old white male presents to the office with worsening dyspnea on exertion over the last year. If this is CCS, this is where that screen stops. Your next screen is going to be a screen of vital signs. What is this? Acute, emergent, or stable, chronic? Answer is, well, there's something going on chronically over the last year, but now he has worsening dyspnea. So before I see his vital signs, I can't guess yet. And again, on CCS, I don't have to guess, because I read the first sentence, and I hit next button, and then I get onto the vital signs right there. But for the sake of this teaching case, and for the sake of single best answer, put me on pause now, read the rest of the question, make your mental bookmarks, and we'll go through it together. Hit pause as soon as you're finished reading. Let's go over the question together. A 65-year-old white male presents at the office worsening dyspnea on exertion over the last year. He was recently treated. So what does that sound like? Man, short of breath for the last year. Now it's getting worse. I think he has some form of COPD. Guys don't usually walk around with shortness of breath for a year. Probably has an underlying disease that he can't help. COPD, he's the right age, he's probably a smoker. I'm making a lot of assumptions here. And he was recently treated for an episode of infectious bronchitis characterized by fever and a productive cough. Are COPD patients more prone for bronchial infections? Yes. Are those infections usually bacterial or viral? Bacterial. Asthma viral, COPD bacterial. He now has a persistent, mild, non-productive cough. Non-productive. That doesn't sound like a bronchitic type picture. He notes a 10-pound weight loss over the last year and has increasingly restricted his activities due to respiratory compromise. Now, lingering in my thoughts from the first time I say the word COPD is this guy going to get lung cancer? Because if he has COPD, 99 times out of 100, he has COPD because he's smoked, and therefore he's at risk for lung cancer. Now I throw in the fact that he's getting worse, And now I throw in the fact that he's lost 10 pounds. I'm very concerned. My number one thing that I can't afford to miss here is lung cancer. Now, frankly, even if he has lung cancer, it's probably too late to cure him. But right away, I hear 10-pound weight loss in a COPD patient and a change in his pattern of chronic symptoms. I'm thinking, am I going to need to do chest CAT scan, bronchoscopy, etc., to think about lung cancer? He has a history of smoking 2 packs per day for 50 years, but denies alcohol intake. All right, so that's why he has COPD, and that's why he might have lung cancer. Again, I don't know if I'm about to find out that his respiratory rate is 40 and he's cyanotic, or his respiratory rate's 28 and he's looks pretty comfortable. Vital signs. Blood pressure 150/80, pulse of 90, temperature 37, respiratory rate of 28. And let me throw in there that he does not look terribly uncomfortable relative to his baseline. Where is this? Well, this is sort of in between acute and chronic, and in this case, I'm definitely going to want to get some more physical exam information before I rush to do anything. All right? Again, this is going on for years. It's been building for several weeks. He's thin and frail. He's using his accessory muscles of respiration at rest. He has no sinus tenderness. Is that relevant? Yeah, maybe he has a sinus infection. He recently had a bronchial infection. People with sinus infections, sometimes they'll swallow what's in their sinuses. They'll cough, they'll swallow what ends up in their lungs. He doesn't have sinus tenderness. He has decreased breath sounds with scattered rhonchi, and increased antero-posterior AP diameter with hyperresonance to percussion. Is this consistent or inconsistent with my expectation of COPD? Perfectly consistent. Decreased breath sounds because I'm putting my stethoscope on his chest, which is out here, and his back of his chest is back here. So I'm trying to listen to those lungs from 3 feet away because all of those years of working so hard with his COPD have increased his AP, anterior posterior diameter. All right? So even if he was moving a normal amount of air, which he probably wasn't, I'm listening to it through a big barrel chest. Okay? So that's why I have decreased breath sounds with scattered rhonchi. There's the increased AP diameter, and there's hyperresonance because those lungs are big, basically dilated lungs. The airways have expanded over years. Heart. Cardiac impulse is visible in the subxiphoid area with a regular rhythm, and S1 and S2 are difficult to auscultate. Why are they difficult to auscultate? Because the heart is about a yard away from your stethoscope. Because it's back here in the posterior chest, and you're putting your stethoscope all the way out here. That heart, even if it's beating perfectly normally and forcibly, you ain't going to hear it too well when your chest is this big. Okay. His abdomen is soft, non-tender, no hepatosplenomegaly. That's nice to know. Doesn't sound like he's overloaded his right ventricle too much yet. Does it rule out cor pulmonale? No, but at this particular moment, he doesn't have signs. I haven't heard about JVD, and I haven't heard about hepatosplenomegaly, ascites, or edema. Next line, no cyanosis, no edema. Differential diagnosis. Again, we all know at this point that he has COPD. And the question might ask us, what tests would I do? What treatment would I use? If the question asks you what's the diagnosis, I mean, this is a giveaway question. But for terms, again, of teaching on these tapes, let's talk about why the other ones are not correct. Congestive heart failure. I didn't hear a lot of rails. Now, can a COPD have congestive heart failure? Sure, that's a not comic. It's chronic, sad. It's a chronic, sad state of affairs. The reason that COPD and CHF often coexist is because the underlying risk factor is the same, smoking. But do I hear rails here? Even though there's a big chest, I don't hear any rails. Do I hear an S3? No. I don't have signs of right-sided failure. I don't hear a history of myocardial infarctions. My suspicion for congestive heart failure here is much lower. Unstable angina, this is not unstable angina. I've heard nothing about chest pain. Mycobacterial infection, COPD, slightly increased risk of TB. Is there anything here to make me think of TB per se? Have I heard any recent travel history? Have I heard of any risks of exposure recently? Have I been told about particular findings on the upper lobes, which is where TB usually happens? No, no, and no. Can he have TB? Yes. Is there any reason to make it number 1 or 2 or 3 on my differential? No. Lung cancer, a big concern of mine. Big concern of mine. Whether it's going to affect my next step in management if he's so short of breath, I don't know. But again, lung cancer is still a big concern of mine. And of course, COPD and lung cancer can very well coexist in this patient. Metastatic disease to the lung, can he have it? Sure. Is there any particular reason to suspect it? No. Chronic bronchitis. That's really a subset of COPD after all. But what is the definition of bronchitis? It's a clinical definition. Okay? The clinical definition is that you have, at least in the last 2 years, at least 3 months a year where you have productive sputum. I didn't get that history. He had a bronchial infection a couple weeks ago. We treated that. Now he's having a non-productive cough. It sounds like he doesn't have a predominance of bronchitic symptoms. Recurrent pulmonary embolus? Nothing here to suggest that. No risk factors for that. Post-obstructive pneumonia. Very good thought. Very good thought. What does a post-obstructive pneumonia mean? Post-obstructive pneumonia means that there's an obstructive, and distal to that, and there's a fixed obstruction, namely a mass, his lung cancer, if he has one, and distal to that, he has a pneumonia that can't clear because it can't get through the airway and let you expectorate all that infection. Right, and that's called a post-obstructive pneumonia. You suspect it in anyone who has what looks like a typical pneumonia. You put them on appropriate antibiotics, and he or she does not have clearance of their pneumonia. Then it's a cancer with a post-obstructive pneumonia until proven otherwise. On this guy, I haven't heard about fevers over the last 24, 48 hours. I haven't heard about anything that sounds like focal lobar consolidation or even diffuse evidence on the chest X-ray, on the exam of a pulmonary infection. So although it's in the back of my mind, if I see a chest X-ray and it has a big consolidation, I'm very worried that this guy might have not only COPD with pneumonia, but a post-obstructive pneumonia. Sarcoidosis, he's not a young to middle-aged woman, more commonly black woman than white woman, with bilateral hyaloadenopathy, period. Every patient you're going to see on the boards with sarcoid, you're going to get in the question that there's bilateral hyaloadenopathy. All right? And you're not going to be able to be asked to make the diagnosis of sarcoid until they feed you that piece of information. Bilateral hyaloadenopathy, usually young to middle-aged woman, can be a white woman, can be a black woman, black more commonly than white. Can it be a man? Yes, but women are much more common. And they will probably give you, not necessarily, but probably other hints of sarcoid, like the uveitis, like a facial Bell's palsy, like hypercalcemia, like skin findings, lupus pernio of sarcoid, like maybe hepatosplenomegaly indicating abdominal visceral involvement by sarcoid. But they will always hand you the X-ray with bilateral hyaloadenopathy. And don't be confused. All that is bilateral hyaloadenopathy is not sarcoid. TB could look like that, lymphoma could look like that, lung cancer could look like that. But you'll never be able to say sarcoid until they give you the X-ray findings on step 3. So right now, what is my differential diagnosis for the sake of CCS and for the sake of single best answer? COPD. Now, how am I going to proceed in this patient? Let's say it's CCS. What would you order next? This is not an acute asthmatic who's running to the emergency room, so you wouldn't lose points on CCS for doing a peak flow, but it's not my major concern right now. This is not an acute serious exacerbation. Would you lose points for ordering a peak flow? No. What do I really want to know? I want to know if this guy has a cancer in there. I want to know if this guy has an pneumonia, or if this is just a plain old exacerbation of a COPD. And what's the first test I would do in that situation? Chest X-ray. If you said he's in the office, you want to do a pulse oximeter, CCS will give you points for that. All right? You do a blood gas first, lose points for that. Okay? If he's not acutely decompensating, there are things I want to do before I take a shiny needle, steel needle, and plunge it into his radial artery. All right? Painful, high risk, etc. I'll do a chest X-ray. I want to be looking for signs and symptoms of cancer or pneumonia. Or cancer. Flat diaphragm, narrow cardiac silhouette, apical bullae. What's the flat diaphragm? Well, those diaphragms have been expanding downwards for a long way, for a long time, and often they flatten out. Has his heart gotten skinny? No. He has a narrow cardiac silhouette because you measure the cardiac silhouette as a fraction of the entire chest diameter. And you have a regular-sized heart in a big chest, it looks like a narrow cardiac silhouette. Apical bullae, don't necessarily confuse this with TB. All right? These are not cavities. These are bullae, large airway spaces. and it happens in the particular form of COPD that we call emphysema, whereby the septae, the walls between alveoli, the walls, here's two individual alveoli, here are the walls between them, there's destruction of those, so now instead of these two little alveoli, you have a bigger airspace. That happens to the alveoli next door, and your air spaces get bigger and bigger. Now, these are thin-walled air spaces that are large air volume in there, but they're very thin-walled, so these are at risk for pneumothorax. Okay? And a bleb, which is a small bullous, bullous is not the right word, a small collection of alveoli we call a bleb, a larger one we call a bullae in the lung. And these can rupture. An arterial blood gas. Again, I'm not in a rush to do it. He is short of breath. I want to know if he's retaining more CO2 than usual. If all I wanted to know was what's his oxygenation, what would I do instead? Pulse oximetry. Okay? But in the COPD, there's the additional issue of CO2 retention. So again, it's not the first thing I'm going to order, but I do want to know his blood gas. pH of 7.36, PCO2 of 46. What kind of acid-base disturbance is that? Is it acidemic or alkalemic? Acidemic. Is it metabolic or respiratory? Respiratory. This guy is a chronic respiratory acidosis. Chronic by nature of the fact that he's had COPD for some time, and his kidneys have learned to compensate by retaining some bicarbonate. His O2 saturation is 94% on room air with a PO2 of 74%. Okay? So he doesn't have resting hypoxia, which is good to know. Would pulmonary function tests help me? Wouldn't help me in my office in terms of making a diagnosis of COPD. I already know he has that. Is it going to help me in terms of how to treat my patient right now, today? Not necessarily. But it does give me an idea of his progression since the last time I saw him. All right? So there's nothing wrong with doing pulmonary function tests. It will give you quantitative information. After all, your lung exam didn't give you very specific information. It just has distant breath sounds and some wheezing and a big AP diameter. At least now I'll get an idea, is his COPD progressing? Is he having a worse day today than during his last exacerbation? Okay? And what are the characteristic findings in COPD? Well, is it COPD or CRPD? It's CO, chronic obstructive pulmonary disease. And what are the features that we see in chronic obstructive pulmonary disease? We see decreased FEV1, the volume of air that he expires in the first second. Right? This is done during a spirometry measurement. It's not done in the same way as a peak flow, where you're measuring a flow rate, liters per minute. You say blow out as fast as you can. That's a peak flow. With spirometry, I want to see how much air you can empty out of your lungs. I want to know your forced expiratory volume from beginning to end. And we call that from beginning to end the forced vital capacity. Can I get every last drop out of my lungs, even if they're healthy lungs? No. There's always a little bit of residual volume. All right? So my lungs are my forced vital capacity plus my residual volume is my total lung capacity. In someone who has COPD, I can't get all that air out. So instead of the residual volume being down here, my residual volume is over here. All right? And the amount of air I could exhale from beginning to end, my forced vital capacity, is less. The amount of air I could exhale during my first second is less. The ratio of how much air I can expire as a ratio of FEV1 to FVC is decreased. Okay? How does the patient look when they're asked to do a spirometry? Say, take a big deep breath in, fill your lungs as much as possible, and then blow out as long as you can, get every last drop out. So it's more like this. All right? And when I can't get anything more out, that's my forced vital capacity. The amount that came out during that first second is my FEV1. In obstructive disease, not only is FEV1 reduced and FVC reduced, the ratio is reduced. As opposed to restrictive disease, if my lungs are very restricted by, let's say, scarring from TB many years ago or from a process called interstitial fibrosis, then all my lung volumes shrink because the lungs can't expand. They're restricted by scarring. So my FEV1, yes, it'll be low because I can't get too much air in. My FVC, yeah, that's low because I can't fill the lungs to exhale. But the ratio of FEV1 to FVC in restrictive lung disease is normal or maybe even a little high. Whereas in obstructive disease, the FEV1 over FVC is reduced. Now, a test that's done less often, because it's not of much practical information in terms of managing my patient, is a diffusion capacity of the lung, DLCO. That is diminished in the version of COPD known as emphysema and is not reduced in patients with bronchitis. Now, from a practical point of view, this is not very useful. First of all, it's not a widely available test. Secondly, my management will not change drastically if I say, yes, this patient has more of an emphysematous pattern than a bronchitic pattern. In reality, most COPD patients have features of both. And other than thinking about the bronchitic patient requiring antibiotics more often, the treatment is really identical. Because when the emphysema patient has an exacerbation, I might treat him or her too with an antibiotic. Okay, and the DLCO in this patient with emphysema, and I told you he has big bullae on chest x-ray, that sounds like emphysema, I expect the DLCO to be reduced. So in the assessment of the patient with COPD, again, the most common risk factor is going to be smoking, smoking, smoking. On physical, you'll see tachypnea, cyanosis, in the patients who are chronically hypoxic, distant breath sounds, rhonchi and wheezing, for large AP diameter, and distant heart sounds, not because there's necessarily a problem with the heart, but because the chest is so big. I'm also going to think about whether this patient has more advanced COPD to the point of developing cor pulmonale, which is right-sided heart failure resulting from COPD, which has been severe and long-standing. What tells me a patient has cor pulmonale? Well, I'll see signs of right heart failure, jugular venous distension, backward pressure from the right side of the heart, a loud P2. Pulmonary hypertension develops in these patients, and the P2, which used to be very soft compared to the A2, which is usually the prominent component of the second heart sound, the P2 is now louder. How do I know which one is which? Because on a deep inspiration, the heart sound that is accentuated in S2 is P2, because I'm doing more right-sided heart filling with a big breath. I might have a right ventricular heave at the sternal border, again a sign of right ventricular overload. I might have hepatomegaly from backward pressure, again a congested, tender, large liver, and I might see some peripheral edema. PFTs in COPD, what do you expect? If you're asked what is the pattern you expect to see, that might be the question. They make it clear a patient has COPD, they have an exacerbation, pulmonary function tests are done. Which of the following would you expect in this patient? All right? Nice, straightforward question. You expect a decreased FEV1 and FVC. Furthermore, that ratio is diminished. You expect to see large residual volumes, and in emphysema, you see a reduced DLCO, reduced diffusion capacity as well. What are the patterns? Emphysema has more airway dilation and septal destruction of the alveoli. Bullae form, and there is a risk of pneumothorax. Patients typically, if they're pure emphysema, and again, there's usually overlap, have a lot of non-productive cough. If you have a young patient, right, a specific, very rare form compared to smoking, very rare cause of emphysema is this genetic disease, which is alpha-1 antitrypsin deficiency, which will present. How will you know it on the boards? It will be a younger person who does not smoke, and they have emphysema. You say, wait a second, this guy doesn't smoke, can't be emphysema. Maybe I should think about PE. No, but they tell you everything sounds like, looks like, smells like, tests on PFTs like emphysema. They want you to know alpha-1 antitrypsin deficiency. One clue, if they're generous, they might tell you that someone else in this family who's young developed emphysema. Someone else who's young who's not a drinker and never had hepatitis developed cirrhosis, because the two organs alpha-1 antitrypsin affects are the pulmonary organ and the liver. Cirrhosis and emphysema. Bronchitis, on the other hand, compared to emphysema, you're going to hear more of a story of productive cough, frequent infections. The chest x-ray, rather than just having big, dilated lung fields, you're also going to see some increased markings because of the chronic secretions and inflammations. And there's a greater tendency than emphysema, bronchitis, to have a lower PO2 and a higher PCO2. How do you treat an acute exacerbation? Okay? Slight variations on the theme from asthma. You want to maintain oxygenation not too high because they're CO2 retainers and they'll become hypercapnic and they'll stop breathing and die if you give them too much oxygen. Common scenario on the boards. You give a COPD of too much oxygen. Next thing they tell you is the PCO2 is 70. What do? Intubate and stop giving so much damn oxygen. These patients, you want to maintain an oxygen saturation 88 to 90%. You're going to give them some beta-adrenergic bronchodilation, nebulizers or inhalers to make them feel better immediately. An anticholinergic bronchodilator is often very useful as synergistic treatment with your beta-2 adrenergic bronchodilator, and you're going to use them in combination. And you're going to use erythromycin or other antibiotics because very often there's an infectious bacterial component, and erythromycin is obviously not the only drug. We'll use erythromycin, amoxicillin, azithromycin, clarithromycin, trimethoprim sulfamethoxazole. All of these are treating the common bugs in COPD, which are strep pneumonia, Haemophilus influenza, and Moxarella catarrhalis. And in fact, ampicillin we're using less because we're finding more and more resistant strains. And here are the antibiotics we discussed. I would stick with the first one, trimethoprim sulfamethoxazole, or perhaps erythromycin. The newer agents, zithromycin, clarithromycin, and the quinolones are far more expensive. How about steroids? Be very careful about the use of steroids in COPD because most patients do not benefit from steroids. So if you're tempted to give your sick COPD patient a trial of steroids, what you must do, and this is the only way you'll get points for doing it on CCS, is do baseline PFTs, start 40 milligrams of prednisone, follow the patient for 2 weeks. At the end of 2 weeks, don't say how you're feeling. Well, you could say that too, but you measure their PFTs. If there's no improvement, stop prednisone. This is not a steroid-responsive situation in that patient. The other drug which I will mention is theophylline. Theophylline, first of all, you never heard it mentioned in the asthma protocol, but theophylline in the COPD treatment protocol has its role in increasing nocturnal central stimulation to breathing and increasing diaphragmatic contractility strength. So it's particularly of value in the patient with COPD who's not responding and has a predominance or a lot of nocturnal symptoms. Okay, let's just finish up our discussion of COPD now. What else do we want to take care of? What else do we want to think about in the management of COPD? And CCS, when the patient is nice and settled and the computer screen says you have 5 minutes left, what else do you want to do? Or maybe even have more than 5 minutes left. You say, what else can I do for this patient? You can always pick up quick, easy points in CCS by doing some counseling, all right, and thinking about lifestyle changes. And COPD is obviously a very big one, and that's smoking cessation. And not only say, well, quit smoking, but take active measures to get your patient to stop smoking, which is nicotine replacement, support groups of other people struggling and probably failing to quit smoking, and most recently the use of bupropion, which is an antidepressant, which can be used to suppress the desire for nicotine. And the way that's used is that the drug is taken for about a week to 2 weeks before your quitting date, while you're still smoking, to try and suppress your desire for nicotine. And then on that chosen date, you put on a nicotine patch, which actually starts the day before or the day that you quit. You continue taking the bupropion as a continued suppressant for your nicotine desire, not as a nicotine replacement, because without using the patch. That actually has allowed many people who have tried many times to quit to successfully finally quit. In long-term management, that's probably the single most important thing you can do, even if it's the most difficult thing to do, is to get your patient to quit smoking, because that'll have an impact on COPD risk going forward. Some changes will come back to normal, rarely entirely to normal in a patient who's as advanced as this, and will also, after a number of years, start to reduce lung cancer risk. Ipratropium is a good long-term type of inhaler to use in your COPD patients. It has a longer duration of activity than beta-agonist bronchodilators, and in these particular patients who are older and more prone to beta-agonist toxicity, it's easier to tolerate. What am I worried about in these older smoking men when I'm giving them beta-agonists? Palpitations, tachycardia, supraventricular tachyarrhythmias in someone who may already have coronary ischemia. So if I can use an effective bronchodilator, I'd rather use ipratropium than a beta-2 agonist. Now, oral theophylline. It is as effective, as we mentioned a few moments ago, for nocturnal symptoms in some COPD patients. The reason theophylline is not used as widely in COPD as it used to be is that it has, again, a narrow therapeutic toxicity window. And some patients, even with what sounds like therapeutic ratios, will start developing some of the toxicities, such as tachycardia, palpitations, very similar to beta agonists. Seizures is a major complication, and it's very important to remember that theophylline interacts with cytochrome P450 and can increase the drug levels of many drugs that are commonly used in this kind of patient. For instance, erythromycin can affect Coumadin and proton levels, etc. So whenever theophylline is being added in a patient on the boards, when they're telling you theophylline is being added, think about what other medications are on that patient's list and if they're about to develop a toxicity from a drug-drug interaction. Now, you might say, well, theophylline, we didn't hear about that once in that patient with asthma. The answer is we try not to use theophylline in asthma. It is rarely used in asthmatics these days because, again, that narrow therapeutic toxicity ratio. And we have a number of other drugs which we discuss in asthma, which we look for first. Are there some asthmatic patients who might benefit from theophylline? Yes, but it's not going to be the first, second, third, or even fourth drug that I would pick. And in asthma or any question on the board, they're not going to ask you what's the fifth most likely drug you're going to use. All right? You want to identify the steroid responders in the way that we discussed. You want to do a baseline PFT measurement, and then after 2 weeks, measure them again. And it's important to remember, and you'll lose points on CCS if you don't remember to ask or give influenza vaccine and a pneumococcal vaccine. How often are these given? Pneumococcal vaccine only needs to be given once in a lifetime. Now you'll say, well, I've been reading that there are patients who get immunized after 5 years. Yes, that's true, but it's not sort of automatic and it's not automatically required. Certainly you want to make sure your patient on CCS, or if it's a single best answer and it's one of the choices, you'll pick pneumococcal vaccine and annual, not lifetime, but annual influenza vaccine. Those are essential points in the health maintenance of your COPD patient. Now, in COPD, we have to think about which patients will benefit from oxygen. You didn't hear me talk about chronic HOMO2 therapy in asthma at all. Why is that? Because asthmatics, between attacks, are normal. Normal in every way. COPD patients, by definition, they don't return to normal function between exacerbations. And many of these patients are chronically hypoxic. Now, it would make sense to give everyone O2 because people who have O2 saturations of 90% chronically, you'll say, well, they'll probably do better with tissue perfusion of 95%. And they might have symptomatic improvement. But there are two situations whereby HOMO2 therapy not only makes you feel better, but makes you live longer. All right? And that's the sort of thing the board wants you to know, is how you can have your patients live longer. There are two situations. One is that your PO2 at rest or exercise or during sleep falls to below 55 millimeters of mercury. This usually corresponds to about an O2 saturation of about 88%. If it is below 55, this patient should receive lifetime home O2. All right, and explain to the patient they don't need to get worried. They're not going to get addicted to it. It'll make them feel better, and it'll lead to longer lifespan. If you're in the 55 to 59 PO2 range, then you still might qualify for HOMO2, but you have to prove to me that your body is really showing signs of decompensating or making bad compensatory mechanisms, such as you've developed a erythrocytosis because there's not enough oxygen to float around. I make more red blood cells to carry it around. And a hematocrit of 55 with a PO2 between 55 and 59 will get you HOMO2 therapy for life. Similarly, if I have signs or symptoms of cor pulmonale in the setting of COPD, that patient should get HOMO2 therapy. And remember, a common scenario that happens on the boards is they give you a patient with COPD, the ambulance or somebody in the ER puts them on 100% oxygen by face mask, and they develop CO2 retention with lethargy, rising CO2, and then hypoventilate and die. So the key is, if you have a COPD patient, if they're going to get chronic HOMO2, make sure it's low-flow nasal cannula O2. And usually the rate is about 1 to 2 liters per minute.